Good morning. I'll introduce you today about my PhD topic about oral health and strategies for the early management of enamel lesions and defects. So I'm Bianca Golzio, and my main vision as a PhD student is to translate clinical problems into high-level science, and my mission is to truly bring to clinical practice the possibilities that we have for non-invasive approaches, especially for enamel. So in order to achieve this mission, these are my current specific goals, and I will just further explain them to you. So my first topic is about the efficacy of CPP-ACP on the remineralization of white spot lesions. So despite the caries reduction that we had after the widespread use of fluoridated toothpaste, untreated dental caries is still the most common oral health condition, affecting over 2.3 billion people. Therefore, we still need to develop new strategies that can enhance and improve the efficacy of fluoride. CPP-ACP could be a product for that, since it is derived from the milk protein casein, it offers no harm, and previous studies have shown that it could reduce up to 58% of caries lesion area after their use. Therefore, we would like to evaluate what is the remineralization efficacy of using a combined CPP-ACP with fluoride compared to using fluoride alone. So for that, our population will be only the patients with early stages of caries. And for measuring this remineralization efficacy, we will mainly use fluorescence-based methods, but also a visual change area of those lesions throughout time. And we hypothesized that actually the combination will be more effective than using only fluoride. So after a systematic search, we have found 15 eligible full texts for the meta-analysis. And just before going to our results, just a quick recap on the outcomes used. So we have used the laser fluorescence, which basically collects the emitted fluorescence by the bacterial byproducts and just converts this into a scale from 0 to 99, correlating with the caries severity. While the KLF, on the other hand, uses an KLF extra oral camera system connected to a blue light, and through this image, they just convert to a software into fluorescence loss and also the area of the lesion that will correlate to the mineral loss of those lesions. So the first results, I'll just show a few. We have here for the laser fluorescence values, and basically all results were divided by time points 1, 3, and 6 months. So here we can see in the 1 and the third month, we can see a pooled SMD of minus 0.30, which was not a statistically significant difference, favoring neither of the groups. And this change would not be considered clinically relevant. As I have shown the scale before, we would expect at least a change, a reduction in these LF values of at least 4 or 5 points in the scale. So for the KLF now, for the fluorescence loss, the scale is a bit different from the LF that I have shown. So we would expect around a difference of 3 points, I would say. And then we can see here that in the 3 months, we actually could find a statistical significant difference, but now favoring the fluoride-only group. But this mean difference of 0.58, it's not clinically relevant. And neither the 1 and 6 months were also statistically significant different from the groups, and neither clinically relevant. So in summary, our main strengths is that we used only RCTs. We did the analysis by the time points, and we also analyzed the change from baseline. While, of course, for the limitations, still the low number of studies and patients, the high heterogeneity of those studies, and the short follow-up time, and especially the outcomes that were used were limitations as well. So in conclusion, we could say that the combination of CPP-ACP and fluoride could not overcome the effect of using fluoride alone for those early stages of caries, and actually the progression of these caries lesions could be reverted by the use of topical fluoride only. So for practice, we could say that this combination has very little beneficial effect, while the daily use of fluoridated toothpaste could provide the remineralization of those white spot lesions. So for research, further large sample studies with a longer follow-up time and also a much more consistent methodology and baseline lesion values as well are needed. And of course, the development of other products than CPP-ACP that could be combined to the fluoride use as well. So our manuscript is currently in the 4th round of revision at the Caries Research Journal, which is a D1 journal. And for our second topic, still on the remineralization topic, but now for the MIH and the non-invasive strategies used for MIH. So MIH is basically a qualitative developmental defect of the enamel that has a global prevalence of 12.9%. And due to the poor quality of this enamel, it is often associated with several complications that could impact the patient's quality of life and even lead to tooth loss. So these complications, they could be minimized or even avoided if an early preventive approach would be taken to avoid these MIH complications for those patients. So that's why we need to understand what is the actual evidence base for the non-invasive treatments for MIH complications, since there's still no definitive clinical protocol established so far on how to deal with those complications. So our aim was to understand which non-invasive strategy was in fact more effective on increasing the mineral content, which is the remineralization, and also reducing the hypersensitivity in those patients. So for that, we would analyze, of course, the patients with the MIH, and the interventions, they range from the CPP-ACP, calcium glycerophosphate, and also fluoride in different formulations. And for the outcomes, the remineralization was again measured by the fluorescence-based methods, and the hypersensitivity according to the pain scales that were used. After the systematic search, we have found 14 eligible full texts, but for the meta-analysis, only 7 studies were included. And here I'll just show the results for the remineralization since the restraint of time. And here we can see again the laser fluorescence changes from baseline. So here, these results, they were divided according to the severity of those lesions. So we had mild lesions, we had moderate lesions, and also lesions that were not actually named by the authors what kind of severity it was. And here in the moderate lesions, we can actually see a pooled mean of minus 4.09, which could mean clinically, a clinically relevant reduction in these LF values, which could correlate with the reduction of the caries severity, with the lesion severity. While in the mild lesions and the mixed, we could not find a clinically relevant number, and these numbers were much lower. For the fluoride varnish now, and just remembering that this is for the CPP-ACP. And now for the fluoride varnish, since we are presenting each plot for each intervention, we had again now the division between mild, moderate, and mixed. And in the mild and the moderate lesion, we could find a reduction, so a pooled mean of minus 3.27 in the mild lesions, and in the moderate lesions, a reduction of 10.39. So we could say that these two values, they could be clinically relevant, especially considering their confidence intervals as well. But for the fluoride toothpaste now, for the mild lesions, we could see a pooled mean of minus 0.53, while in the moderate lesion, there is actually a positive number of 9.89. So this could mean that actually the LF values have increased, which could correlate that the lesions have progressed over time with the use of fluoride toothpaste only. So in summary, our main strengths is that this was the first quantitative analysis of the available strategies for MIH, and we did the analysis according to the lesion severity, which could provide us more information. But of course, the limitations were the low number of studies in patients, and also the study design used in the included studies. And also there is a broad range of different treatments and also different lesions. And using the laser fluorescence as the only outcome was also a limitation. So in conclusion, we could say that the moderate lesions, they had a tendency to have a better improvement than mild lesions throughout time. And fluoride varnish, CAGP, and CPP-ACP had a moderate but a relevant clinical effect on those lesions, while fluoride toothpaste was not enough to decrease those LF values, and lesions have progressed. And for practice, MIH requires a very complex management, and we should take into consideration also the severity of the lesions. And other non-invasive strategies should be combined to the use of fluoride toothpaste. And of course, still further need for more studies with better control and higher patients' numbers, and new strategies should be developed as well. So this current manuscript is being finished and will be submitted to the Journal of Dentistry, which is a D1 journal. And finally, just a third topic is about understanding the oral health inequalities in financing across Europe, which is based on the Eurostat data, which is the statistical office for the European Union. And we would have access to these statistical data. So we would just like to know which socioeconomic factors are associated with the access to dental care and financial burden in the European countries. So currently this project is under the request for approval to have access to the Eurostat microdata, and is still in the initial phases. So these, in summary, are our main 3 topics, and we plan to finish them by January. And these are some of the additional activities that I have done in the past year with IADR. So I'd like to thank you for your attention and leave you with this quote. Thank you very much.
Thank you, Bianca. Would you like to stay or you may also sit if it's better for you?
I'm
okay,
perfect.
You're just fine. Okay. Okay, so first of all, again, from the audience, any questions? Yes, please, up there.
Thank you, Bianca, for your beautiful presentation. I have 2 questions. The first is about the second topic. I have seen that you have 4 interventions. Were you interested in network meta-analysis in this case, or what was the reason you cannot done any network meta-analysis in this?
Thank you for your question. So of course this was our first trial to have a network meta-analysis, and we have not chosen only those interventions, but we wanted to analyze all the available interventions. But the main problem was first the design of the studies, because we didn't have enough RCTs. We had RCTs and cohorts as well. And even for the RCTs, we didn't have enough connections, direct and indirect connections. So it was really hard to, so we actually spent some time trying to design a network and seeing how the data would look like, but it was not possible. And that's why we ended up just doing a meta of the means and just dividing by each intervention.
Thank you, it was very smart. And the second question is connected to your first topic. In your conclusion, you said that this CPP-ACP is not better if you are using it with fluoride. So in the practice, what can you say to your patient? Because there are, I think there are many brands containing these agents. So what can you say to them that please don't use this because this is not really necessary to use it, it's just a waste of money, or what can be your suggestion in your clinical practice, because this is your vision to translate it to your practice?
Sure, that's the main question, and we have to remember that we were comparing, and also our conclusion is that the combination was not superior to using fluoride alone. So then remains the question, why to even use this if this is an added value for the patient? And also it's even harder for the patient to have compliance. We know that patients barely have compliance on brushing their teeth. Imagine just compromising with using an extra product. So in general, from these results, we could just, we wouldn't recommend to use necessarily the CPP-ACP because of the price and also the patient's compliance. We have other issues as well. So the results could not support enough evidence for that.
Thank you very much.
Thank you.
Okay, my second question was already asked. So my first question, in your first study you used SMDs. Why, and how could you make a clinical relevance or clinical meaning for your results?
So we have used both SMDs and MDs. So for the LF we have used SMDs because it was different somehow how the values were reported. So we had to make a lot of, so we had median, we had mean. So in the end we just had to had an SMD from them. While the QLF we had a more consistent reporting of the values, and that's why we used the MD. So we have decided on these two based on how heterogeneous the values were and how they were measured.
How did you handle that you had medians and means? You made the SMD from these?
That's what we agreed on doing for handling these differences. And actually the ideal would be to have, but we had a low number of medians actually, but the ideal would be to have median values for that, especially because since we have the numbers, the means could distort a lot of the actual values. And actually one of the questions that we had from the reviewers was about that maybe it was better to report the median values than the mean values, but then in the end we mostly had the mean values from the studies and we could not do much with that.
Thanks.
Thank you.
Thank you for the presentations. I used to think about bias, so my question is again about bias. So Have you investigated the inspiration, motivation, efficacy in the research groups and test groups and control groups? Because that's an important issue. And the second question is about the methodology, because there are other methods to investigate the crystal structure of the enamel, like Raman spectroscopy, and it might give us additional answers about the efficacy of the remineralization methods, because it's possible that... Are you a dentist?
Yes.
Great. So, there are additional factors influencing the effectivity of the remineralization, and the laser fluorescence not necessarily gives us all the answers.
Of course. So regarding the first question, it's very hard for us to measure this because we're collecting the evidence from the studies, and they usually just mention this as, of course, a limitation and a bias about the motivation. And some studies, they do not mention anything, and some studies, they mention that it was a big problem, and the patients actually reported that they stopped using after some time. So this is...
So at least we do know how to set a clinical trial.
Exactly. So it was not very consistent on how the different studies, they have been transparent about this lack of motivation or the lack of compliance from the patient. So of course, when we are analyzing the daily use of something, especially like this for 6 months, we have this problem. So we cannot know exactly whether these results were because of the lack of efficiency of the product or the lack of compliance of the patient. And regarding your second question, just a pregnancy brain, what was the second?
Raman spectroscopy. So the structure of the crystal.
Yes, that's a very good point. We have also a lot of other methods, and of course, laser fluorescence is not the best one because this is just collecting basically the fluorescence from bacteria. So of course, the plaque could be a huge limitation factor on this. But then, since we're collecting from the studies, usually what they use in RCTs for this topic is either LF or QLF. So these were basically what we had to deal with, and also we had some visual area change. So they just collected some photos, and they just did, in some softwares, just collecting how much the lesion has decreased in size. So it's an issue that actually we need to change a bit the clinical practice for the research to use other methods as well. Any
registry set up already?
Not yet, but that's a very good point. We need to know much more information about this, and especially for MIH as well.
God bless your delivery, and then let's design perfect clinical trials for that. The hypomineralization, the second story. So do we really know what is the cause of this? Because we haven't seen, and I'm asking my colleague, Dr. Barta, 25 years ago, we haven't seen that much hypomineralization cases. So what is the reason? And is there any chance we can figure it out what is the cause, the increasing incidence? And second, any hope to develop a protocol to treat those children?
There are 2 points on this. Maybe 25 years also, it wasn't named as MIH, so there's also this problem. It was maybe not diagnosed because we didn't have a proper diagnostic criteria for that. So when we see back in time with the studies, we just have these issues because then the name was not consistent and people could not know what exactly they were seeing. So we also have this problem. But in general, there are many factors, as we all know. If we check MIH, there's a lot of studies regarding the genetic backgrounds of that and everything, and we cannot really find something, but there's thought to be a connection also with the fluorosis, so we can see that there's something within the same time in the enamel development and mineralization that is going on. So we need to explore much more, not only the clinical side, because of course we need to know how we treat those patients, but also the background factors of what could actually influence on that, and genetics seems to play a big role onto this, and this needs to be further investigated. So, I mean, we have to combine both studies. We need to know how we can actually deal with the patients, but also come to foundation points of the whole MIH and what is also connected to in the enamel development.
I think, but this is also a very interesting question for us obstetricians, you know, because so should genetics be the background, then we could not see this elevation in the last 25 or 30 years if this elevation is a real one. And then my question is, I mean, what do you think about this question? So something happens during pregnancy with the development of the fetus, during the development of the fetus, or after delivery during childhood or in the early years? So what is your gut feeling?
It could be both because, but really in the first infancy is where it usually deals with the problems with enamel that we have. So, but of course, not much is known, we could say. So we could even figure out something that happens before, but usually in the first infancy is where these defects, they come from. So we need to further investigate what are other, because there's also trauma and there are many other issues that could happen in the first infancy that could actually affect this. So even prescriptions intake, antibiotics, so and actually there are a lot of respiratory diseases that seem to also have a correlation with that. So there are many, many factors that we could see that actually could have a correlation with MIH. So this is a very new topic, very broad, and not much information that is known, and could be anything at this point.
Thank you.
Thank you.
Dr. Barto, you may have also questions.
Some questions. So I think remineralization is very important non-surgical method of the caries therapy, so it is important. First question is, which method you prefer, you propose for a dentist for early caries detection?
That's $1 million question. If we check the evidence, for example, there was a review in 2022 that analyzed actually KLF, laser fluorescence, also FOTI. And if we look at this evidence, and unfortunately I don't have the clinical background onto this, but if you look at the evidence, they show very, very similar clinical accuracy of those methods. So it really depends on, of course, I would say laser fluorescence, we cannot correlate that exactly with the caries lesion severity, even though it's a good method of actually analyzing objectively and having actual numbers. But FOTI is actually a very good option, and there are also newer methods that were developed with near-infrared transillumination as well. So these are all coming up, especially transillumination, I would say, would give a more accurate result for that.
But the dentist uses mainly radiography. What do you think about it?
We need to combine both visual, I mean, radiography, especially if you're talking about early stages of caries, would not be the best choice. So we need to combine somehow the visual examination with some other methods that can measure this objectively, so we can actually track down what happens with time and with the products as well.
Okay. What do you think, how acts fluoride during the remineralization?
Mm-hmm. So basically, two ways of the fluoride action. So when we have fluoride in the oral cavity, we just have a replacement of the hydroxyl ions to the fluoride, and then we have fluor hydroxyapatite, which is a more resistant mineral to the subsequent acid challenges. But also what is known is that the actual fluoride present constantly in the oral environment at low concentrations is the one that actually protects from the demineralization and also enhances the hemineralization. So that's why we always need to make sure that the patient is constantly brushing their teeth and constantly having the fluoride in the oral cavity to maintain this balance between the demineralization and the hemineralization.
And enamel, which was remineralized with fluoride, is different from the enamel which was remineralized with some calcium-containing product?
Yes, because the enamel structure changes. So from fluoride, we have fluoride hydroxyapatite, while the other ones, we don't have this replacement from the hydroxyl to the fluoride ion. So they're constitutively different.
Thank you. The fluoride containing toothpastes are similar in effectivity, or there are some differences?
In these studies? So they were mainly similar because they used the same, the same component for the fluoride, so they were similar between each other. They just had different ppms, but around they were 1,500, so they were around the same on those cases. But of course, we could have different formulations, and this could also impact in the results of that.
Thank you very much.
Thank you very much.
Hi, Bianca. I have a question regarding the MIH. When I just heard that it was increasing in the last 25 years, have you thought maybe about doing a survey and then contacting all the mothers, which babies or which children who have MIH, and then maybe investigating what happened during pregnancy, what did they take, and maybe we can then find out the reason for the MIH. That was everything.
That's exactly what Dr. Naj mentioned, that maybe doing a registry so we could have a continuous upload of those data and just retrospectively assessing this information. Especially in Hungary, I don't think we have an MIH registry, so that would be very valuable, not only here, but also having connections with other places so we could have this information as well.